Welcome to The Rally. This podcast includes commentary and conversations about issues relevant to clinical psychology. It is intended to educate, entertain, and enlighten, and is not a substitute for actual mental health treatment. Individuals who share personally here choose willingly to tell their stories to benefit you, the listener. All other references to clinical situations are altered or limited to protect confidentiality. For more specific questions or help with a personal situation, please consult a local mental health professional. Therapy, mental health, real life. This is Psych Rally with Los Angeles-based clinical psychologist Dr. Martin Hsia.
Thank you so much for tuning in for episode 8 of Psych Rally, which is brought to you by OCD. OCD is a mobile app aimed to help people with obsessive-compulsive disorder manage, confront, and beat their symptoms of OCD. The OCD platform does this by collecting personalized data and coordinating with clinicians to help customize a treatment plan for patients to take with them on the go and obtain guidance whenever and wherever their OCD may be a challenge. For more info, you can check out www.treatmyocd.com or download the OCD app on your smartphone or smartwatch. Alternatively, you can check out the show notes for episode 8 here at the Psych Rally podcast website. All right, our guest today is Dr. Rodney Boone, fellow clinical psychologist and the founder and director of the Cognitive Behavior Therapy Center of Southern California, where we practice together. You can check out our website, by the way, at www.cbtsocal.com. Prior to this, correct, Rod, you lectured for 17 years with the Department of Psychiatry at UCLA. Is that correct?
Yes, there's an anxiety disorders clinic there, and for years I was one of the trainers, doing cognitive behavior therapy there.
In the anxiety disorders clinic, and in my understanding, you were also at Harbor UCLA training their psychiatry residents for a long time as well.
That's correct.
Gotcha. Okay, so a wealth of experience and wisdom. Which I've been fortunate to benefit from in our time working together. And not to mention you have lots of other affiliations and roles with other professional organizations, and I can only just mention a few in the interest of our time. But that includes, but is not limited to, the International OCD Foundation, the Anxiety Disorders Association of America, and the Academy for Cognitive Therapy. In your excessive free time, that all of that has afforded you. You're also a fellow Dodger fan and baseball fan, right?
Yes.
We're not off to a good start this year, are we?
Yeah, we're holding in there. We're only 4.5 games behind.
Kershaw 7-1. We'll take that.
Yes, we will.
Yeah, weak division so far.
Yes.
Right. And my understanding is was it you who told me that you once caught a foul ball?
Oh, I've caught a couple of them, actually.
A couple of foul balls.
One of them was at Old Candlestick Park, and it was back in the days, and I really shouldn't say this on the air any longer, but I was a Giants fan because I grew up in the San Francisco Bay Area.
Maybe I can edit that out if we need to later.
Right, exactly. But I've also caught a ball from the Dodgers.
Really?
So,
not the Gibson home run ball in the '88 World Series? That
unfortunately, no.
That would be worth something. You're also an accomplished photographer and world traveler, to my knowledge, most recently to Antarctica, Jamaica, and pretty soon to Burma, is it, right?
That's correct.
Okay, and of all your world travels through the course of your lifetime, if you had to pick one most memorable place that you visited, what might that be?
Well, that would be Antarctica. I had really very low expectations about going. My wife dragged me, who is also a clinical psychologist, by the way.
It's not a top tourist destination for most people.
No, it's not. And it wasn't for me either. It was certainly not on my bucket list. I didn't know enough about it to put it on my bucket list. But and it was exceptionally hard to get there. It's it's a long way away by plane. And then you've got to get into a ship and go 2.5 days, 650 miles across something called the dreaded Drake Passage. And we were just sicker than dogs, basically. They were 30-foot seas. But we came out of that into the kind of the shadow of the Antarctic Peninsula, and it was like a Jules Verne moment. It was like there was a whole world down here that didn't look like any place I had ever been. It was just fantastically beautiful, and it was really completely memorable.
Sure.
So that. I'm not sure I would. Well, I would actually be interested in going back. That was just it was like visiting another planet, actually.
I'm sure, yeah. And not overrun by American tourists or
No.
gum all over the ground and
No,
stuff like
no,
that, right? A couple other questions for the audience to get to know you, Rod. Is there a book in our field from all your years of experience that you find yourself recommending the most in your clinical practice?
Well, I recommend the Mindfulness and Acceptance Workbook for Anxiety by Eifert and...
Is it Forsyth?
It's Forsyth.
That's right, yeah.
Yeah. And it's about 10 years old, but and it represents a kind of what we call kind of third wave cognitive behavioral orientation called ACT, or Acceptance and Commitment Therapy.
Right.
And it very neatly dovetails with much more recent research that has really informed kind of state-of-the-art cognitive behavior therapy. So I find that I recommend that often as a workbook for people to work along with the therapy as we go through it.
Okay. On a personal note, is there a work of art, film, music that has left a particular impression on you that you could share about?
Yes.
I'm sure there's many, but if you had to pick one.
There are many, actually. There is a room at the Los Angeles Museum of Contemporary Art where there are a number of Mark Rothko paintings, these huge paintings that are big rectangles of color. And I find them just deep and meditative, and they're just fabulously beautiful pieces, and they've really influenced me as a photographer. My photos are not direct translations of Rothko paintings by any means, but I've a lot more and more my photography is getting more and more abstract, and there's an affinity, I think, for Rothko.
Cool.
So it's made a big impression on me aesthetically.
So if I needed to track you down on the weekend, I could go over to Mocha in downtown LA, and you'll be standing in front of there.
Right.
Okay.
Come and rescue me.
You just gave away your hiding place to me. Okay. And any personal event or experience that taught you a particularly valuable life lesson or left an impact on you that could be helpful for people to hear about?
There's a couple of them. I'm going to start with a personal one in my life. I was let's just say at best, an indifferent high schooler,
Okay.
Academically.
At best.
At best. And my parents, in a moment of wisdom, sent me off at the age of 16, to something called Outward Bound.
Right.
And I don't know what the condition of Outward Bound is at this point, but it was life-changing for me. It was actually designed, I think, 100 years before as an alternative to war. It was noticed that actually some of the useful things about sending men to combat is that they grew up very quickly. Mm-hmm. And, obviously there's
downsides
to the whole thing. But it was really an attempt to try to help young men in those years to really get challenged. And so for me, one of the things that I learned two things basically. That in those days it was for a month. You would go off, and it was in the Colorado Rockies, and you would not see civilization for approaching a month. And what happened with me is I slowed way down and really had my first experience of being kind of a part of the environment, and not just this isolated human, but actually integrated into the natural world. And that that was deeply influential. The other is that they just challenged you.
Huh.
You had to, one of the times we had to walk for 30 miles in one day. And in order to do that, you've got to start walking before it gets light.
Oh,
you have to walk all day long, and then you have to walk a number of hours after dark. And so at a certain point, you're way beyond your physical
They're just
limits.
exhausted, yeah.
But you keep going. And so one of the things that I learned was that limitations are not really physical for the most part. They're mental.
Mm-hmm.
And so that has helped me my whole life, actually. And if you think about what we do in terms of psychotherapy, is that we're kind of helping people move beyond their sense of their own limitations. We'll come back to that a lot probably today.
Right.
So that was very, very meaningful for me personally. As a segue into what we're going to talk about today, you and I had decided that we were going to discuss some of the features of obsessive-compulsive disorder,
right.
OCD. And I want to tell you about my first client with OCD. And this was 30 years ago. Actually, it was probably 32 years ago. I've been licensed for 30 years, but I had a psych assistantship underneath a practicing psychologist at that time. And so he said, your first case is to go see this woman who had severe OCD. And she was so severe that I had to make a home visit. Mm-hmm. And what I found was a woman who had a terrible contamination fear. She feared that something bad would happen if the outside came into her house. She was never able to really, at that point, articulate what was so bad about that, the quote unquote outside. But what she did is when her husband, she couldn't leave, and her husband would go out to work every day, and when he would come back, she would insist that right at the doorway, he gets out of his shoes and he strips down totally, taking his clothes, drops them into the washer, and then goes to the shower and washes in this very ritualistic way.
You'd think she was in some sort of research lab.
Right, exactly.
Yeah, gosh.
Well, she was in a way. She was she could have had incredibly great laboratory technique because she was attuned to all those small, precise ways of doing things.
Right.
But even worse, she had to do this decontamination all the time. So she took 6-hour showers.
Wow.
And her husband stopped being able to afford to buy shampoo and conditioners and things like that. So she would wash her hair with bars of soap.
Wow.
And by the time I saw her skin was broken out. Her hair was kind of matted. And she would count time in a way by how many bars of soap she would use during a wash.
Wow.
She was, actually one of the more severe cases I've ever seen.
It happened to be your first.
And it happened to be my first. But the thing was, I thought I found a freak, but it turned out to be just this human underneath.
For sure.
She was very smart. She had a wonderful sense of humor. And she, in a funny way, was this ordinary human being who had to do all these things because she was so uncomfortable with this idea that the outside would intrude upon her inner world. I don't want to go into the details of the treatment because we're going to talk about treatment for, somebody with OCD. But by the end, she got down to where she was taking a 30-minute shower, which was a vast improvement.
Sure.
She was able to leave the house. She was able to go and take her kids to school and pick them up, and she got 85% more functional.
Mm-hmm.
Wow.
But
what I really learned from her is that these people that look so strange and do these strange things are actually really they're humans like you.
They're just
and
everybody
me,
else out there walking
basically.
around.
Absolutely.
Yeah, but I've just gotten stuck in a really restrictive and destructive pattern of behaving and avoiding.
Absolutely.
Yeah.
And let me just say something about OCD. I mean, to paraphrase Tolstoy in Anna Karenina, where he says that all happy families are happy in the same way, and all unhappy families are unhappy in their own individual ways. That what I've found over the years, and doing work with a lot of people with anxiety disorders, that panic people, all panic disorder people, tend to kind of look the same way. They panic in roughly the same ways. However, when it comes to OCD, people, because of their history and their individual personalities, have OCD and express OCD in these radically individual,
unique
idiosyncratic ways that make working with them, I think, just very interesting. Above all the people I work with, I think that OCD is actually one of the more challenging disorders to work with, but also rewarding because it's so rich in a human way.
For sure. And it's the kind of thing where you can see tangible progress.
Absolutely.
In that process, yeah. And as you say, I mean, you can measure it in a sense from a 6-hour shower to a 30-minute shower. And I'd have to think this being, again, one of your first client ever, you said. Yeah. And that's kind of sets you off on a career arc of, hey, this is, something that's clearly a severe problem that people need help with, but that's rewarding to work with and that you learned a lot from. So thank you for sharing that.
Yep.
Yeah.
Absolutely.
Well, so let's talk a little bit about OCD in general, because you hear a lot of stuff out there. I read a lot of stuff out there. People who are, not in the field will say, oh, so-and-so is so OCD about yada, 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 about their desk, about their closet. And just like you hear, oh, I'm ADHD because I'm, spaced out for a moment, or so-and-so is bipolar because they were irritable one day. There's a lot of misuse of these terms, and OCD is, I don't know if this is just my lens, but it feels like it's abused and misused even more than some of the other terms. Maybe in your own words, sort of talk about how people talk about OCD versus what actually is OCD, Obsessive-Compulsive Disorder, diagnostically.
Well, you do hear this. Didn't Calvin Klein or Ralph Lauren in the last 15 years? I think they're still out there. There's a perfume called Obsession. And
there was an obsessive Christmas disorder or something that came out this year on Target sweaters, and there was a whole controversy about that. Anyway, you just hear these funny things.
So absolutely, that people have, talk about being obsessed with this or being anal.
Right.
Being really picky, perfectionistic, somebody who has to have things a particular way. But when we talk about OCD, we're really talking about something else. In fact, talking about the anxiety disorders in general, I think it's really important to remember that these come out of normal human experiences and feelings, and then all the anxiety disorders are just exaggerations of normal experience. So with somebody, that 30 to 40% of quote unquote normals who never go on to experience panic disorder have experienced panic attacks one time or a number of times, but have never just gone on to sort of that. So these are all normal experience. It's
along a spectrum, if you will.
It's a spectrum,
yeah,
basically.
Sure.
And so what begins to distinguish these quote unquote normal OCD experiences from pathological or diagnostic OCD is when it really when the suffering goes up. When it really, what you're doing, trying to manage the OCD, really begins to impair your ability to live your life fully, to enjoy your life. And so at that point, it really becomes diagnostic.
It's one thing to say that I'm perfectionist, I hold myself to a very high standard, or I'm a neat freak, I like to keep my room or desk or work area very organized. It's another thing to say I have OCD. It's causing a problem. It's impairing my life, right?
Right.
Or that there's a level of fear attached where the compulsions or efforts to neutralize that fear somehow exacerbate the fear.
Yeah,
Yeah?
exactly.
Sure. Well, and this is another piece is interesting is, we think of the C in OCD, the compulsions piece, which can look different, again, as you said, because OCD can take on many forms for different people. But how do you distinguish between a compulsion for someone with OCD versus, say, an addiction? Because there's some overlap in the sense that this is sort of, there's a behavior or an aspect of something that I'm, doing a lot of and having a hard time not doing. But how do you distinguish the difference between those two?
Well, it's a very interesting question. You see things called compulsive, like I'm a compulsive shopper, or I'm a sex addict, or I've take methamphetamines, and I have a gambling addiction, and how is that different from OCD? What's very interesting is that OCD is never positively reinforced. It's only negatively reinforced. And let me explain that. Anytime in psychology where something is reinforced, the behavior that's being reinforced is much more likely to occur. And so what positive reinforcement is when you get pleasure out of doing the thing. So with sexual addiction or shopping addiction or drug addiction, gambling, there's at least initially, there's always pleasure involved.
Something being added.
Yeah, you like what you're doing. You're getting something out of it right away.
You work and you get paid. You press a lever and a pellet of food comes out. Positive reinforcement.
Right, positive reinforcement. Yeah. But the other thing that happens with all these disorders, including OCD, is something called negative reinforcement, where it gets you out of a bad physical or mood state. So if your life is falling apart because you're going through a divorce, and you've discovered that when you're in Las Vegas gambling, you don't even think about it. And so it's, in addition to being positively reinforced because you enjoy it, it also gets you out of, thinking about something that's going to make you feel badly. When you're addicted to a substance, as you the same thing is occurring, but also you may be physically addicted, so that when you stop taking that substance, you go into withdrawal, and so that you would retake that substance to not
more
feel,
likely do the behavior again.
Yeah, you would in order to not feel the withdrawal
Sure.
symptoms. With OCD, as I said, there's no pleasure in it ever.
Yeah, right.
And what happens with people is that they're trying to do a ritual or an action to keep the bad thing from occurring, to reduce their anxiety, to get out of that bad mood state.
Yeah. And typically, OCD traditionally being under the anxiety disorders umbrella, right? There's a fear. There's an anxiety of some negative image, feeling, or thing happening that I want to escape from.
Right.
Right. The compulsion sort of, in the short term, gets rid of that feeling of fear. Yeah.
Right. It initially works, and that's why you do it. You wash your hands if you've got a contamination fear.
Yeah.
You check if you've got a thought of harm. You want to make sure that you didn't actually harm somebody. Say, you want to, initially if you've got a symmetry issue where you need to have everything ordered in your environment, initially straightening it out like that it works for you. It gets that discomfort, that fear away. But what happens, and we can talk about this more, the more you do that, the less it works.
So, as you said, initially and short term, it works. Over time, less so.
Right.
Yeah, that's
why it persists, basically.
Or it can even grow.
Right.
Yeah. Okay. Right, and again, as you said, to distinguish from an addictive behavior, at least semantically, right? An addiction may not be something that develops alcohol, drugs, what have you, because of anxiety. That certainly could be one reason that some people develop these behaviors to cope with anxiety, but it's different from a compulsion in that sense. Right, because you can develop it for lots of different reasons, not necessarily because you're neutralizing an obsession or irrational fear. Yeah?
That makes sense.
There's something out there called Pure O, it's not in the DSM, but a sort of form of OCD and we've had some conversations about this. Is in your mind, is it a real thing, or can you say what it is and your experience with it, if you will?
Well, puro is pure obsession with no compulsions, and I think it probably ought to lead into a discussion about what actually OCD looks like.
Yeah.
But puro is where, theoretically at least, you have the obsessions but no compulsions. There's no attempt to try to neutralize what's going on in your head. And I have to say, with over 30 years of experience with OCD, I've actually never seen a case that I think that if you drill down far enough with anybody who theoretically has no compulsions, you will find mental compulsions of some sort. You will find avoidance, and you will find mental compulsions.
So I've heard some different things here. In some places, I've heard puro defined as obsessions without the compulsions, supposedly. But then I've also heard some people who have said puro means there are compulsions, they're just not visible. They're not behaviors. They could be a mental compulsion of some sort. So it's suppose, again, it's semantics, but what you're saying is similar. If there's obsessions, more often there's some, if not in all cases, there's some effort to avoid or neutralize it.
Exactly. And in my experience, again, there's always that. There are either external physical compulsions like washing your hands, but it could be just trying to rethink, replace a bad thought with a good thought. Mm-hmm. And that is clearly compulsive, and it's not something that shows on the outside. It's not a quote-unquote external behavior, but it's a mental behavior.
Right, and will serve the same purpose and ultimately not be successful. Mm-hmm. Yeah, well, and that's an interesting piece, too, is at least in the media, and actually we see this sometimes in our offices, people, they've come across some sort of issue that turns out to be OCD, but they didn't realize, this is OCD too, because all I thought it was hand washing and fear of contamination. It sort of seems like that's the most, I guess, publicly known version of real OCD, which is a real form, of course, as good as it gets with Jack Nicholson, those kinds of things. But there are other forms and presentations of OCD that we see here that don't get as much media publicity. Can you maybe say some of what those are?
Mm-hmm. So again, Martin, like you just stated, the most frequent OCD picture is contamination, where there are obsessions of, that there's something that you have gotten contaminated with, and then you go through some sort of procedure to decontaminate yourself. And a lot of the popular press has really, over the last 20 years, really pointed out that, and that's why there is more of a popular idea that that's OCD. Mm-hmm. But nearly as common is something called harm OCD, thoughts of harm, where you might have a thought where I was working with a woman who was terrified that she might lose control, she might go crazy, and she might harm herself. She might kill herself.
Not because she was depressed and wanted to harm herself, right?
No, this was a thought that would come to her and that would scare her. Yeah. And so what she would do is try to be supervised all the time by her husband or her parents. She had to, when she would drive to work, she would have her husband follow in a car right behind her to make sure that she didn't do anything.
Wow.
And then he would go on after she got to work. She couldn't be near any knives or anything like that. And so
basically just couldn't be alone for fear of what she might do, even if she didn't want to do it.
Exactly.
Yeah.
So there's thoughts of harm for self, thoughts of harm in terms of others. I had a woman who was very afraid of knives because she was afraid she might stab her spouse. And again, she would have kind of ordinary periodic irritations at her husband, but she really had no interest in actually stabbing her husband.
Sure.
And so she was, again, alarmed by these thoughts and would go through elaborate ways to avoid, the possibility of doing that. There's also, and this could happen, thoughts of harm could have a sexual content. Yeah. That you could be a pedophile, or you could, rape a member of the opposite sex. Then there's something that's actually kind of a subgroup of that some people call gay OCD. And that's where, say, a heterosexual person might have a thought. I mean, there was this 19-year-old kid that I worked with some years back, and Kobe Bryant, a great Lakers star, and he was a big sports fan.
Yeah.
And he one day noticed as Kobe was about to shoot a free throw, just how great though his shoulders looked. They were really powerful.
Which they were.
Yeah,
This
absolutely.
is a top athlete in his prime.
And
right?
then he said to himself, "Oh my God, why am I having that thought?
Right.
What does it mean? Does this mean that I'm gay? Does this mean that I want to have sex with Kobe?" And he spiraled down to where he would, he's a 19-year-old, he's watching porn all the time, and he'd kind of close one eye and squint because he didn't want to have to see the male in that. He only wanted to look at the female. It was too dangerous for him. He couldn't read Sports Illustrated anymore because in Sports Illustrated it showed guys in shorts and things like that.
Lots of guys in good shape and showing skin.
Absolutely. Yeah. And so he couldn't look at guys in the face, couldn't look at them at all, walking down the street, because he would think, well, what if I find that I have desire for men? So just for the record, there's been some cases where gay men have been disturbed by what they viewed as heterosexual thoughts.
What if I'm actually straight?
Right.
Yeah.
And it was, just as distressing for them.
Well, and in some of the cases we've consulted on before too, is it and again, it's very different from being homophobic or even anti-gay for a lot of these folks, right? I have friends who are gay. In some ways I don't have a fear that people around me will not accept me or that my family will reject me if I come out. It's just right. It's just that what does this mean? This is going to be so different for me and my life, and that there's a fear attached to it, even if they're not opposed to people of the opposite orientation or people with a different lifestyle. I've seen that in a number of cases.
Yeah, oftentimes it's just so at odds with what their core sexual orientation that it's when one has a thought like that, it's important to say that OCD is just an exaggeration of normal experience. Everybody thinks everything. There are some landmark studies that go back decades that really showed that what distinguishes a quote-unquote normal person from somebody with OCD is not the content of their thought, but whether or not they reacted to their thought with fear.
Right. Interesting.
And so, newborn parents all have thoughts of harm in terms of you have young kids. You probably had the experience with a newborn where you sat there and noticed how vulnerable that child was.
For sure.
And how easy it would be to drop the child or throw the child against the wall. Not that you wanted to do that, but you would have a thought, and that it was triggered by your observation of the vulnerability of that child. That is a normal thought.
Sure.
But somebody with OCD would say, and does say, oh my gosh, why am I having that thought? What does it mean? There's the belief that thoughts have meaning. Every thought has equal meaning. And so,
or that the meaning must maybe is that I actually want to do that, or I'm capable of doing that.
Exactly.
Yeah.
The two of those things.
Yeah.
And then they start doing all sorts of compulsions to kind of prevent that from happening.
Well, I just think, as you said, sometimes thoughts can be generated just as like a blip of neurons within our mind somewhere. But also, like, people will talk about how I heard about something or I saw something on TV. I heard a story on the news about someone who committed suicide by jumping off a bridge, and I drive over a bridge every day. What if I could picture myself it doesn't mean I want to, and then that can be scary. Well, and I
think what's really important for people with OCD to know is that is one of the functions of our human brain. It's to generate options all the time. It's like a popcorn machine that just generates all this, popping of thoughts all the time. When it has great survival value. When we reach an obstacle, if our brain just stayed in the same mode, we would get stuck, and we do get stuck. But because it is the source of our creativity,
Sure.
and so it generates all these ideas, and so 99% of them are pure junk. They're not. They don't lead to a
Actual
great
solution
or
Sure.
or if it's a creative idea that this one is worth keeping or anything like that. But people with OCD don't realize that, and they think that if I'm generating thoughts like that, it must have meaning. It must be what I feel.
Well, it makes me think that in the human spirit, our imagination is one of our biggest assets, but can also be scary.
It's a double-edged sword. And
right.
I see that with OCD
Yeah.
a lot. And one of the things I tell people is that you really can't have OCD unless you have a creative imagination. And so that you can image all the things that could be catastrophic.
Sure. One of the things that I found interesting too is the sort of religious scrupulosity form of OCD, having come from a Christian training program, and the sometimes kind of rigid and formulaic ways that I think all religions in some contexts can be preached or practiced, but how that can also be very lead to a form of OCD where if I don't say whatever 8 or 15 Hail Marys, that because I had a sexual thought or an aggressive thought, that what if that means I'm going to hell? These kinds of things, which can really be disturbing when you throw a existential element into it.
Well, scrupulosity is actually really interesting, and it's really one of the first forms of OCD that was defined, and was defined 1,000 years ago by the Catholic Church, who, a classic example of, nuns praying in a chapel, and then what gets formed, you kind of formally marry Christ.
Yeah.
And then the thought of Christ's erect penis comes into mind, and that you can imagine how shocking that would be for anybody. But in that setting, that would be just completely disturbing, wondering if that's the devil doing that, or if that's proof that they're evil people and are going to go to hell, excuse me. And so there might be an attempt to kind of wash that thought away, to try to pray it away with those Hail Marys. Yep. And so the Catholic Church quite early saw that was not true religious behavior. And and so
they didn't call it OCD at the time.
They didn't call it OCD. And so an example of that is I was working with somebody a number of years ago. He was very smart. He was working in a pharmaceutical firm, very high up in management. And he had a Catholic background. And he felt that if he didn't make the sign of the cross when he would enter a Catholic church, if he didn't do it perfectly, he was compelled to repeat it, to get down on his knees and do it.
Until it was right.
Well, and even more so, he had to feel it. He had to get a religious feeling in a way at the same time, or he had to repeat it.
Right.
And he would get stuck doing that over and over and over again.
In the short life of this podcast, that's the first time Christ's erect penis has been mentioned. I have to say that. OCD, in your experience and our experience, I should say, as we've consulted in our practice here, can often be disguised as, or sometimes overlap with a few other diagnostic categories, if you will. A lot of things we've talked about, and sometimes it gets lumped together with hoarding disorder, which is a new disorder of its own, with trichotillomania, excoriation, and the BFRBs, the body-focused repetitive behaviors, and body dysmorphic disorder too. Maybe can you just comment briefly on some of the overlaps and the challenges you've seen in your practice?
Well, there was a very interesting time. I think the media has been very helpful in the last 20 years because there's been these popular books that have come out that have illustrated some of these disorders. In the Watershed book, I think it was around 1990, was The Boy Who Couldn't Stop Washing, and it was a book talking about Prozac and how useful it was in those days with OCD. But what it did is it talked about OCD, primarily contamination OCD, but it also talked about something called Trichotillomania, which has now been changed to its hair pulling disorder, which is much better than something that ends with a mania.
Right.
Trichotillomania sufferers for years have been complaining about that because it's not a mania at all.
No.
Actually, it's just a habit, but it involves compulsive hair pulling. And so I began to see a lot of people who would come in after reading that book and saying, I pull my hair, I must have OCD, can you help me? And initially I tried to use the same techniques that we use so successfully with OCD with people with hair pulling disorder or skin picking, nail biting, and it didn't work. And it was the first indication to me that this was not really OCD.
Yeah.
And the same thing with hoarding disorder. And body dysmorphic disorder. These have this kind of compulsive behaviors attached to them, this repetitive behavior, but that does not mean that they're the same disorder. And one of the things that has been helpful in the research in cognitive behavior therapy is that, and one of the things that ought to be said about CBT, that there's been from the very beginning this ongoing research in trying to find techniques that work with disorders that actually really help people. And so there's a scientific basis to CBT and this ongoing research. And what has come out of that are specific techniques for different disorders. So we have a set of techniques, which we probably should talk about at some point.
Which we will.
For OCD, but we have also different techniques for these BFRBs.
Right. Sure. Yeah, well, and as you said, maybe sometimes, or some of the reasons why these things have gotten lumped together is behaviorally, there can be a repetition, a compulsion, a difficulty stopping something, so they look similar, but perhaps the mechanism, the place that those behaviors are coming from are very different, so you just can't conceptualize and approach them in the same way.
Right.
Yeah. Perfect foray, by the way, is so within the CBT world and treatment for OCD, I mean, traditionally the gold standard and things that we draw from often is the exposure model, exposure with response prevention, a lot of research done by Edna Foa and her associates. But I know that there's also been a lot of changes and developments in the research, which I think are interesting. If you can share a little bit about that too.
Well, I'm wondering if we should step back for a moment and really talk about what treatment looks like.
Sure.
So what keeps OCD going and actually all of the anxiety disorders, and you could actually say that a lot of the mood disorders too, is avoidance. One of the things that happens with all the anxiety disorders, and in particular OCD, is that your life gets more and more restricted as you attempt to avoid these catastrophic outcomes.
You can spread across your whole life.
Absolutely.
Make the world very small.
Like that, first client I had who really didn't leave the house. And that's why I had to, after 6 months, she was able to come to the office. Yeah. But I had to go every week.
That was already a lot of work. Yeah.
So one of the things that you have to help people see is what they do. If I feel that if I sat down on the sofa here and I'm afraid I'm going to get hepatitis C from doing that if I go and I wash my hands, that even though I might feel some relief after 5 minutes of washing, because I think I've maybe dodged the bullet at that point, it really keeps the whole OCD pattern going. The OCD pattern is the obsession part is where I get this thought as I'm sitting here, Martin and I'm sitting in Martin's office, perhaps he's had people who have been IV drug users and might have hepatitis C, And it's, I'm not sure how well Martin cleans his sofa. And so I have this thought that is I'm a threat thought. And so I begin to get really anxious. I feel very vulnerable. And then I feel compelled to go wash. And so
get rid of that feeling.
I get rid of the danger and get rid of the feeling. So, but what it does is it just keeps it going. The next time I have this thought, I sit in some other waiting room, say, and then I think the same thing. I'm going to go do it. So that what happens really is all learning stops. You are just doing the same thing. The beliefs that you have are unchallenged and unchanged. And so what we do is help people challenge those beliefs by reversing the avoidance, by starting to approach these situations. And it's a really exciting therapy, actually, because people, when they see that what maintains it is their avoidance, and they get ready to touch something and not wash, it's the formal term for that is exposure with response prevention, so that that person exposes themselves to the thing that they fear, and then they prevent themselves from doing the ritual or the behavior that they did in OCD. And so what it does is it propels them into a new situation for them where they can learn again.
Learn something new.
They can learn something new about their fear and about themselves, actually.
Well, it may be learning something that they, at some level, know, perhaps, but have buried over with the time repeating the compulsion.
Yes.
Yeah. So what I often see is there's that tension or contradiction between people say, well, I know objectively, of course, I don't want to jump off the bridge, or I know that washing my hands once is fine, but that compulsion is so strong, the fear is so strong that I can't change the behavior. Yeah.
Sometimes OCD is called the doubting disease. I mean, so like I go and I check the front door before I go to bed. I make sure it's locked, for example. And as I click the double bolt, the bolt lock, that feeling, I absolutely know that it is locked.
I'm safe. Yeah.
Right. Okay. But then as you start to go away, somebody with OCD would say, but the stakes are huge. But what happens if, maybe I wasn't paying 100% concentration on it. So you go back and you unlock the door and relock it. And the problem is that sensation is actually not identical to that first one. And so that feeds the doubt. Even though you're trying to reach certainty with it, it feeds the doubt, so that you do it again. You unlock the bolt, and then you lock it again. And now we've got a third sense impression that is stacked over the first two. And again, there's going to be a slight mismatch. And so what you find people doing is getting caught in this. They start looping, we call that.
Yeah.
Where I remember actually one of my earlier cases, this was a woman who called me very, very late at night, and she had spent 2 hours trying to make sure that her the gas was off on her range.
Wow.
And she was trying to tell herself OFF as she's reading the stove
to make sure
off,
that it's off.
Off, and going over it over and over and over, and getting less and less certain. And checking compulsions are very interesting, because what we are able to do with repetition, doing it over and over again, is you actually temporarily rub the meaning off of a particular action and or thought, and we lose that sense impression. And so then it just feeds the panic, basically,
right.
and people get really lost in that, and it's terribly frightening.
Well, sure, and the ability to use one's reason and logic to fight and to think oneself out of the pull to do the compulsion becomes more and more impaired. Yeah. Well, clearly there is so much we could say about this topic. But Rod, for now, is there any other sort of take-home messages or final thoughts on the topic of OCD for people listening, either people working with OCD in the practice or perhaps someone who themselves or someone they know may be dealing with OCD?
Well, I think that I feel very privileged to have been able to do this work over my professional career. It's actually transformative. It doesn't seem like it would be, but for somebody to really begin to take the enormous risk of not avoiding any longer, but actually facing the situation that they've been terrified of and actually moving into that and experiencing it anew is just life-changing for people.
Yeah.
And not only on the OCD level, but they really get a sense of their own courageous self. And it is radically transformative in terms of their self-esteem and self-image. And to be able to be a part of that and actually to observe that kind of growth is really gratifying.
Sure.
So I've, so enjoyed the privilege of being able to work with, individuals suffering from obsessive-compulsive disorder.
Unlike so many other things as a therapist, we have tools and training and ways that things that we have at our disposal to help people change, but ultimately, we're not really in the driver's seat. It's up to the person to make the changes and be open to hearing the things that we're wrestling with together. So, as you said, to be on the other end of that, to observe that, to see the change is really powerful and meaningful. So, as we said, there's so much more we could say. So maybe we'll have to do a part 2 if you're game.
Sure.
Yeah. So appreciate your time, Rod.
Thank you, Martin.
Okay. And that's Dr. Rodney Boone of the Cognitive Behavior Therapy Center of Southern California, cbtsocal.com. Yeah, he's really just a master of understanding and working with people with anxiety disorders and specifically OCD. And for a psychologist, therapist of my generation, I'm very grateful to have people, to have someone like him to work side by side with and draw from as a mentor and teacher. What's your story with OCD? What's been helpful? What hasn't? What's been the most difficult? What do you wish people would know? Clinicians, family members, typical people out there. Let me hear your story. Tweet me at Psych Rally, send me an email. We will see you on episode 9. Thank you for tuning in.